Looks good. Are we live? Okay. Good morning, everyone. Happy New Year. I hope everyone had some time to rest and relax and recharge and spend time with loved ones over the holidays. Excited to welcome everyone back for the second semester and the first grand rounds of the new year. We've got a familiar face and a new face, or relatively new face, to kick things off for us here in 2025. Dr. Anna Naiman is the relatively new face. She joined the Rainbow faculty in the fall of 2023. She's not new to the Cleveland area, though. She grew up in Cleveland. She went to Case Western Reserve as an undergrad before moving to Toledo for med school, and then went off to Indiana for residency and pediatric fellowship at Riley Children's Hospital. They had the good sense to retain her for several years as a faculty member before we successfully recruited her back to join the Division of Pediatric Endocrinology, as I said, in the fall of 2023. For anyone who was paying attention to the announcement for Grand Rounds this morning, you might guess that her research and her funding and numerous articles and abstracts are in fact related to pediatric diabetes. I won't list the numerous publications because I'm guessing that some of that research may be reflected in this morning's talk. I'm also guessing, fairly safely, I think, that one of the things that helped get her back to Cleveland would be a chance to work with Dr. Rose Gubitosi-Klug, a very familiar face. She is also from the Cleveland area. She left Cleveland to go to St. Louis, where she did her undergraduate and MD PhD training at WashU in St. Louis. We then successfully recruited her back for her internship. In fact, she was part of the second intern class that I ever had got a chance to work with when I was a junior faculty member here. And in the intervening years, she has certainly developed a reputation as a national, in fact, international expert, particularly in the field of pediatric diabetes. And more locally, I think it is very safe to say really one of the pillars of the Rainbow and Case community. I cannot cover or do justice to all of her CV this morning, but in light of this morning's topic, I think it's quite pertinent to point out that aside from her personal research, she has really become well established in multiple multi-center trials. I'm going to have to refer to notes to make sure I get this part right. She has gained experience in multiple NIH-funded multi-center clinical investigations, including co-chair of the landmark Diabetes Control and Complications Trial and the Observational Edict Study, which was a follow-up. That's the Epidemiology of Diabetes Interventions and Control. She served as vice chair of the Treatment Options for Type 2 Diabetes in Adolescents and Youth, referred to commonly as the TODAY Study. And most recently, she is the chair of the new Discovery Consortium, focused on the epidemiology and pathophysiology of youth onset type 2 diabetes. Again, I suspect we will hear more about that work in this morning's talk. So I'm really excited to hear about this collaboration and learn more about type 2 diabetes from our local experts. I don't know who's starting this morning, though. All right, I give you Dr. Naiman.
Very exciting to see everyone. I have a special interest in type 2 diabetes, and I'm really excited to share all this with everyone here and anyone listening. So we're going to talk about current knowledge, how it affects people today, and then Rose will talk a little bit about future directions and some of the studies she's currently involved in. So we're going to just start with some background, epidemiology, current treatments, and then we'll go into future directions. So the SEARCH study was really the first observational study. It looked at type 1 and type 2 incidence, prevalence, risk of complications, quality of life, really like natural history. So this is the update to the SEARCH study. And unfortunately, it does show an increase incidence in type 2 diabetes in youth, with the highest rates for those youth of Hispanic, non-Hispanic, Black youth, and really high rates of increase in Asian Pacific Islander youth. In 15 to 19-year-olds, the overall incidence of type 2 is actually higher than type 1, which is really kind of remarkable. And I think this is really important because we all see people in our general clinic, and the rate of screening and diagnosis, so really it went up from about 25% was diagnosed at just a routine visit to about half. So it shows the importance of general pediatricians because we're picking up these cases a lot earlier. And really some of my focus will be how important that is. That really early intervention in youth type 2 is very important. Peak incidence is about 16, except in non-Hispanic Black youth, which is a little earlier at 13. And it's important to note that this rise is actually in comparison to an adult, where there's some studies have shown a decrease or at least a stability in new type 2 diabetes. There's a lot of different reasons why people think of this increased incidence, the parallel rise of obesity. We are doing a better job of screening and diagnosis. Also, there's a lot more antibody testing. So those that we thought had type 1 actually have type 2 diabetes. So the Today study that was already mentioned, the original Today study, so we had this knowledge that it was increasing from the original Search study. And Today was really a treatment study. What is the best treatment for youth with type 2 diabetes? Initial study was metformin plus Rosie, and metformin plus intensive lifestyle intervention, with the primary outcome being treatment failure. So about half failed at about a median of a year, which is really, it's a high rate, especially in comparison to adults. And after completion, because at that time, Rosie, even though it was better Rosie and metformin in terms of the rate of like a decreased rate of failure, there were a lot of reports of concern for heart failure in adults. And so when they had a follow-up study, they were either put to metformin or metformin plus insulin. Here are the updates. And what's really important is we think of this, but these are young adults, about 13 years after diagnosis, 26 years old. I mean, that really is thought of as a healthy time in your life. And as you can see, the rate of A1C unfortunately only increased, with many a 9%, 10%. And you can see that, I think, really nicely in this graph below, where a majority had an A1C of less than 6.5%. And then just within a few years, it was the minority, with a good amount of people having an A1C of over 10%. And we know that that is not good for your long-term risk of microvascular, macrovascular complications. So important to note that unlike type 1, a lot of people come in already with having some complications. And so hypertension, about 20%, dyslipidemia, same, early kidney disease, about 8%. And this graph just shows at 50th percentile and then at that 15 years. So at 15 years, the cumulative incidence for kidney disease was about half, nerve disease about 32%, and retinal disease about half. Again, it's important to note these are young people in their 20s. And it's also important to know how many baseline already had a complication, because we know that that means that things are starting before we're diagnosing people. And that's important to know about intervention. So about 60% of participants developed at least one, about a third, about two complications by an average age of 26, average duration of 13 years. The primary driver was glycemia, with additional risk factors of race or ethnicity, blood pressure, insulin resistance, and dyslipidemia. So it's important to kind of put this in the context of youth with type 1 and also adults with type 2. So again, these are about adolescents. They've had a diabetes for about 13 years. Kidney disease was about half at that point. In type 1, about a third had diabetic kidney disease after duration of 25 years. In adults, about 25% after 10 years. So again, these risks are much higher in our youth with type 2 diabetes. So really the conclusion is that unfortunately in these young adults, the risk of complications increased steadily over time and affected most participants by the time of young adulthood. And pregnancy, I mean, this is a really important part. These are young adults who think about children. Some of these are unexpected pregnancies, but these are important. So this glycemia doesn't just affect that person, but also their future generations as well. And so there were 260 pregnancies reported in this follow-up study. Contraception used prior to pregnancy was only about 13%. Complications were reported by 65% of women. And again, these is an average age of 21 years old, with preterms about a third, which is about triple the national average. A1C about over 8% in about a third of the pregnancies. And so this table just shows, unfortunately, the risk of complications in both preterm and in term births. And you can see a high rate of neonatal hypoglycemia, which makes sense, but also a high rate of congenital anomalies, including cardiac anomalies, both in term and in preterm babies. And there was also a really high rate of miscarriages in this population. So now the more recent studies rise. So really this kind of came with an idea of maybe we just need to be, if we can give insulin earlier, if we can get really good tight control earlier, maybe we can reduce the risk of beta cell deterioration. Because really what we're seeing is beta cell deterioration early, much earlier than an adult with type 2. And so that's really where RISE came from. There was both a youth and a pediatric arm. They did hyperglycemic clamps. In the youth arm, it was just metformin and insulin. GLP-1s at that time were not approved. They tried really hard to get Trulicity in the youth, but that was only done in the adults because it wasn't FDA approved and they didn't let it be studied in the RISE study. But as you can see, the primary outcome, so it's either metformin for 12 months or insulin for 3 months and then the metformin for the rest of the 9 months. And you can see in this really nice graph that even though you'll see that their glycemia improved, like they had tight control, their beta cell deterioration, it got worse on treatment as well as off treatment. And so none of the treatments that was studied, which is the primary treatments at that time for type 2 diabetes in youth, stopped this progressive deterioration of beta cell function. So you looked a little bit on the background. So you see that in the pediatric data, they actually have this really robust response to these clamps. So they have this like hyper responsive beta cell you think would be a good thing, but then they underlying have this like deterioration of this beta cell. So it's like, is it a good thing or is it almost, they're having this hyper responsive response, but then they're also deteriorating in the background. BMI increased between 3 and 9 months in those on insulin. A1C transiently decreased at 9% in the pediatric group, but then it went back to the baseline. So this is important because this is actually what updated the 2025 ADA guidelines is some of this data. And so it's really the natural progression of type 2 in youth. And these are updates on the Today study, for example. So a baseline cutoff of A1C of 6.2% was optimally predictive of loss of glycemic control at any time versus an absolute rise of 0.5% related to loss of glycemic control within 3 to 6 months. And this is important to note because we say an A1C goal was less than 7, but a lot of people would be less than 7 and you'd see them back however many months later and they would have deteriorated. And so this is really important to note. And this is also showing that even those that had early good glycemic control, they still had better control than those who had higher A1Cs, but everyone went up. And fortunately, even those that had good A1Cs, in the background, their beta cells still deteriorated, even with these A1Cs that were initially really good and tight. So the RISE extended the findings of today. Metformin and insulin plus metformin were ineffective in preventing beta cell deterioration, prediabetes, or early type 2 diabetes in youth, even when initiated early in the disease course. And then some of the secondary findings, we saw a little bit of that weight gain with insulin. I'll show you a little bit later about in today, even when they had concern about glycemic failure and they gave insulin, that still most of those still had elevated A1Cs. And so the idea was that insulin did not prevent further beta cell deterioration. So now we're going to move on a little bit to treatment. So we have our background. We know why it's important to treat. So we all know, just like with youth with obesity, that dietary physical activity is very important. And then we're going to also touch on medication therapy. So we have anyone with new onset diabetes meet with our diabetes nurses and educators for full diabetes education. And really our recommendations are similar for all youth that who have obesity. And so we participate in 60 minutes of moderate to vigorous physical activity and strength training at least 3 days a week, and to decrease sedentary behavior, which is really important, especially in the winter. As we all know, it's very hard, it's dark, it's cold. So really trying to work with the families about what can you truly do in Cleveland and what can you do in different environments and different social situations. We focus on key nutrition principles. So eat more non-starchy vegetables, whole fruits, legumes, whole grains, nuts, seeds, low-fat dairy products, and really eat, some of these things focus on is just really, can we reduce the pop? Can we reduce the sugar sweetened beverages? Like, what can we truly do? And that's why I think it's important to get a little bit of that diet history, because you can say these things and write these things on your discharge notes, but really it's important to say, what are you currently doing and what can we do? And sometimes it's even like, can this just be maybe something we do on Saturdays or something we do on Sundays, or, kind of really work with the family, because sometimes blatantly saying none of this, none of that, like it's not really reality. And I think it's really important. It's why in EPIC that it does have that food insecurity questionnaire. And obviously social workers are not available in every clinic. But I think it's important to kind of understand the background because we do find a lot of food insecurity and we do have availability for those referrals. And it's important to try to see, where it comes from, if there are things that we can do to help. So this is hot off the presses, the 2025 ADA guidelines, which is similar, but does have a few important differences, which I will highlight. And it really has actually, I would say, at least changed over the last 5 years because now we say A1C less than 8.5, some people say 9, but really metformin is still first line, which has been first line for a while. But I think what's really has changed is this paradigm in this you're not in DKA HHS. So it's over 8.5. Even with really high A1Cs, you can have some ketosis. But if you're not in DKA HHS, really thinking about only starting prandial insulin. And that's been a huge shift because it used to be that we treated youth, and I mean in my early training, not like we used to treat youth with type 2 diabetes pretty much the same that we treated youth with type 1. We would do metformin. People wouldn't like regular metformin because it gave them diarrhea. They would stop the metformin. And then they would just be on basal and bolus insulin. The problem with basal and bolus insulin is a lot of times people will get diabetes burnout. They would gain weight. Eventually their A1Cs, not everyone, but many people would rise. Then they would stop taking some of their insulin, kind of depending on the day, and then they would disappear. And so really, it's important to know that if you're suspecting type 2 diabetes and they're not in DKA HHS, even if they have an elevated A1C, you do want to start them if they're, 10, like you want to start them on that prandial insulin, but it doesn't mean you have to start them on bolus insulin. And that's really important but saying all that, there are plenty of people who have elevated BMIs who really have many risk factors for type 2 diabetes who eventually you get their antibodies and they're all very positive. And so they really have type 1 diabetes, even if they phenotypically very much look like someone with type 2 diabetes. So it's very important to get diabetes autoantibodies. And especially now that we also have the zinc, there are quite a few patients that have had 3 negative and a very, very positive zinc autoantibody. And so really getting those antibodies when you make these treatment decisions is important because they will come back. And if things look very differently on the antibodies, you can always add bolus insulin. But again, if they're all negative, now you've only done prandial insulin. So in one that has decreased their, because you're teaching them carb counting, you're teaching them like all of these things that then just increase the burden. The other thing is that, the risk of hypoglycemia is low, but at the same time, if they do have it, sometimes they'll just stop everything or they'll only stop their prandial insulin. So it's kind of important that this is an important time where you can really focus on what can we do to maximize therapy. DKHHS, you treat the same. I mean, you're still going to put them on a drip. You're still going to kind of treat them in that fashion because they have metabolic decompensation at that point. And we have seen really, unfortunately, very severe, especially combined HHS DKA, which is a really tricky thing sometimes to treat. And so again, we have seen people come in very sick and you do have to treat them when they're very sick. But once they're out of that phase, then again, you can kind of reconsider where they fall in the paradigm. So if they're positive, type 1 diabetes, again, even this is a little bit of a gray zone if we're talking about one mildly positive GAD or we're talking about multiple very positive antibodies. If the antibodies are negative and you've, they're, let's say, on prandial insulin and metformin, then at that point, they've really shown that you can safely wean most people off of insulin within a few weeks. Because a lot of times what happens, and you'll see it in type 2 diabetes, is unlike type 1 can definitely honeymoon, but a lot of times you'll see more of these excursions. In type 2 diabetes, a lot of times initially, they're very hyperglycemic, like stability kind of wise, like all 200s. But then once you treat them, eventually they'll come down and they'll just be very kind of stable. And so sometimes what happens is people are like, oh, these sugars look great. And then they just like keep them on the same doses. But in reality, that's when you need to be weaning that basal insulin. And really trying to maximize metformin because sometimes people have it in different sites. They have different strategies. Some people start everyone on extended release. Some people start everyone on regular to have extended release on their back pocket. That way, if they have, diarrhea or things like that, I think they're like, well, let's try extended release. So there's a lot of different ways you can do it. But I think the important part to know is someone says that they have abdominal complaints or diarrhea, not to just cancel it because it's an insulin sensitizer, which is really important if you're going to be weaning the insulin to have them be on an insulin sensitizer, is trying to understand like, okay, if they're on regular, can we switch them extended release? Is it just that they went up to 2000 and that was too much? Because I have a lot, especially where I was before, we do like a lot of there's extended release 500s, but also 750s, and two 750s is 1500, and they would do fine on that. They just didn't like the 2000. They didn't like take 4 tabs a day. So it's important to kind of meet them where they're at, or the tabs are too big on extended release. That's also a problem. You start everyone on extended release, they don't like it because the tablets are really big. They like the regular because they're smaller. So not saying like automatically they stopped, but what, there are variations in different formulations. The other thing that's important is this has really been a focus, really starting in 2024 when other agents got approved in pediatrics, and even more of a focus actually in 2025 is the non-insulin agents. And now they're even really more explicitly saying, before it was just like consider, but now it's like really try to maximize these non-insulin agents before you add on, especially bolus insulin. And prandial insulin in type 2 can go really high. You can put someone on a really high prandial, like a basal insulin dose, before you need to be adding, food or carb coverage or things like that. So metformin still remains first line. Again, we talked about the 50% treatment failure versus adults, and it was a different study, but similar time frame, only about 12%. But treatment failure did plateau over time. So there is a subgroup that responds. And I think me, Dr. Farrell in the back, like we see people who do respond to metformin. It's like no one responds to metformin. However, we do know that there are groups, such as in non-Hispanic Black youth, that have a much higher treatment failure on metformin. Also, it's important to know that that baseline A1C of 6.3% predicted treatment failure. And again, that follow-up study was 6.2, and really that rise of 0.5%. This is really where now the ADA has agreed with this ISPAD. ISPAD used to always be less than 6.5, or at least the more recent ISPAD. But ADA was still less than 7, which is similar to type 1. But this is kind of where it's saying, like, actually, we say they're in target, but maybe they're at high risk for glycemic deterioration if we don't intervene even earlier than 7%. Insulin, so this is the follow-up on the today where it just showed that when they added insulin to those who had glycemic failure, A1C of less than 0.55% was seeing a difference within 6 months. But then after a year, there was no significant improvement with an mean A1C of 10%. So it really just, again, points to this fact that unfortunately, there's this like underlying beta cell deterioration in many patients. And so it's really hard to achieve good glycemic control once you've severely depleted those beta cells. So this is that 6.5 that we talked about. Now they align, where we say that if you're less than, and this is just recent, like in 2025, that ADA aligned with a 6.5%. And so again, if you're less, but if you're, 6.5 or above, again, thinking about those non-insulin agents, especially, because we know that just going up or adding in more insulin can potentially increase diabetes burnout burden, but also just weight gain. So really thinking about those non-insulin agents as well. So GLP-1 agonists, I think we all see them a lot more frequently because we see them not only in type 2 diabetes, but also in our youth with obesity. SGLT2 inhibitors. So I'll talk a little bit about the 2 studies that came out. The first one, they didn't show a primary benefit in their primary outcome for A1C, but they did in like a secondary analysis. And then the second one, which was for the Jardiance, did show that improvement in A1C. And that's what led to the FDA approval in 10 and above, which is the same as GLP-1s, 10 and above in type 2. SGLT2 inhibitors in adults appear to be renoprotective. We don't really know about cardiovascular protection yet. And in those studies, in really all pediatric studies, they did not show that improvement in blood pressure and BMI in youth. But again, the doses studied in GLP-1s are lower than the doses that are studied in adults and in obesity as well. DPP-4 inhibitors was the exact same study that was for the SGLT2 inhibitors. They did not show an improvement in A1C, and so that's why that was not approved in youth. TZDs, so Rosie was that first one that was in the Today study. It did show it was more effective than just metformin alone, but it's not recommended in youth because of that increased risk of heart failure, fracture, macular edema reported in adults. It has like a black box warning for heart failure. Pioglitazone is actually used more frequently off-label in some centers because there's positive effect in beta cell function today with the rationale of improved insulin sensitivity and our beta cell function observed in adults that outweigh this theoretical risk. More data is needed. And sulfonylurea was used for a brief period of time in youth. I mean, it's still used in adults, but the glipizide study it brought up this concern that it was actually going to accelerate beta cell decline. And so it's not very commonly used in youth with type 2 diabetes. It also can have weight gain and hypoglycemia, but really this concern about beta cell decline is why we don't really use it. So incretin therapies, I think it's important to know that, you eat something and then you release. But these are like glucose kind of, it's not like you're fasting and these are working. So how does it work? It works on many different areas. And I think that what's nice is this is a little bit of a complicated slide, but I just wanted to show that you eat. You eat and then you release GIP. So those are those dual. So tirzepatide, Mounjaro, Zepbound, those are those dual incretin therapies. So in this case, GLP-1s are in red and GIPs are in blue, but you kind of release them from the gut and then they go all over your body and affect probably good and bad in different ways. But in the good, it goes to pancreas and it releases insulin, decreases glucagon. In the gut, it will delay your gastric emptying. It works we know you have receptors in the brain. It makes you more full. And then it also, for the GIP, it has it in your fat tissues as well. So the original GLP-1 study was actually in daily. So it was in liraglutide or Victoza. That's what led to the original approval. The first weekly was Bydureon, but Bydureon, the old Bydureon, it used to have these, like a lot of people would have these welts. They did not like it. And then Trulicity, which is on formulary for most formularies here, is primary. And so this is the study that got, dulaglutide approved. And so it improved that A1C as well as the secondary, fasting glucose, a higher proportion of those than A1C of less than 7. The important part to note is in that dulaglutide study, they show like a statistically improvement in BMI, but it was only 0.75 and 1.5 milligram dose. In adults, you go up to 3 and 4.5. Semaglutide, that was studied in STEP teens, which was a study for obesity, and that's what led to its approval. But that was there's the kind of two brand names, Ozempic, which is for type 2 diabetes, and Wegovy, which is for obesity. And so it was studied at a 2.4 milligram dose, and it showed the same 16% weight loss versus 0.6% in placebo improvement in lipidemia and hepatic steatosis. So again, semaglutide Ozempic is 18 and above. Wegovy, which is for obesity in youth, that is 12 and above. But it's showing that maybe some of those studies that we didn't see the improvement in BMI also was the doses it was studied at. SGLT2 inhibitors. So what's really nice about having, very exciting that we have SGLT2 inhibitors approved in 10 and above is because a lot of even though, with GLP-1s, right, you make sure that people don't have a history of pancreatitis, obviously no family history of medullary thyroid carcinoma or MEN, but most people, if they have issues, they have it with the gut. And what do people mostly have issues with metformin? Also the gut. And so it's nice because SGLT2 inhibitors work at the level of the kidney. And so usually they don't have the same kind of GI side effects. So if it's someone who really can't tolerate some of the other medications, it's nice to know we have this option. Also, SGLT2 inhibitors are pills, and some people really don't like injectables. And so it's really nice. It's a much smaller pill than the big extended release metformin. So it's nice to kind of have those options. So it works at the level of the kidney, and the SGLT2 is expressed in the proximal tubule, mediates reabsorption of about 90% of the filtered glucose loads. So it promotes that renal excretion of glucose, so it modestly lowers the blood sugar levels in those with type 2 diabetes. So this was the original dapagliflozin study. This is the one that the primary outcome didn't show an improvement in A1C, but the pre-specified sensitivity analysis of the protocol compliant participants did show an improvement in A1C, and there were no new safety signals, which was really important because part of these are safety studies showing that we're not seeing differences in terms of youth having higher risk of complications. This is the one that did lead to the approval in kids. And so this is empagliflozin, which is Jardiance. And so we did see an improvement in A1C. This also had the DPP-4 inhibitor, which didn't show it, which is why DPP-4 inhibitors weren't approved in youth. So just a little bit about tirzepatide, also called Mounjaro for type 2, Zepbound for obesity. Again, this is not yet approved for under 18, but we hear about it a lot. And where does this come from? So the original SURPASS study was in adults with type 2, which showed that decrease in A1C and BMI, which led to the approval in adults. SURMOUNT, which is the obesity trial with at least 20% weight loss and more than half with the highest 15 milligram dose, again, led to that approval. And SURPASS PEDS, it's fully enrolled. And so hopefully we'll get that data soon. because that I think would be a really important thing that we could then offer, hopefully, our youth with type 2 diabetes as well. So just a little bit, because I'm sure you guys, it's really interesting because especially these dual agonists, but also Ozempic or semaglutide, they're using it in a lot of different ways, not only in those with obesity and not only in those with type 2 diabetes. This is adult data, but it just got approved, tirzepatide for obstructive sleep apnea, improved in adults with moderate to severe OSA. There was just a phase 2 study in adults with and without type 2 diabetes with MASH who had stage 2 or 3 fibrosis, which really showed significant improvements. And I think we see that in our pediatrics too, not just specifically tirzepatide, but even GLP-1 agonists, those that have non-alcoholic fatty liver. And they did a semaglutide versus tirzepatide study in adults that showed an improvement, higher improvement in weight in tirzepatide versus semaglutide. So metabolic surgery. So Teen Labs, it's like kind of the big study. So in youth with type 2, there was a 95% diabetes remission 3 years post-metabolic surgery, decreasing about half by 10 years. Teen Labs, that's those with and without diabetes. So 3 years, they were looking at different complications. So 3 years post-surgery, there's a remission of abnormal kidney function, about 86%, about 57% at 10 years, pre-diabetes, and 76% in blood pressure, 74% of dyslipidemia, 66%, 54% at 2 years, and a higher diabetes remission rate. And then they try to compare this to medical therapy, and there's no, we will have more data to have because other sites are directly comparing these things, like putting people in bariatric surgery versus medical therapy. So we will actually have direct comparison studies not that long from now. But this is retrospective data. They used the today's study and saw how people did surgery versus medical therapy, what their outcomes were. So then during the 5 years of follow-up, BMI decreased in the metabolic surgery group by 11 BMI units, an increase in today. A1C went down in the bariatric surgery versus went up to 8.8% in today. And then there were other improvements in other insulin sensitivity, other complications in the metabolic surgery. Again, I think soon we will see the direct comparison, and obviously surgery is surgery, so it can have these risk of complications. But I think what's important to understand about this data is that it should be considered in those who have type 2 diabetes, class 2 obesity, who have an elevated A1C and or serious comorbidities despite lifestyle and pharmacological intervention. So, it is, but again, this really, if you're going to do metabolic surgery, because these are youth, this needs to be in a place with an experienced surgeon, well-organized, engaged in a professional team, surgeon, endocrinologist, dietitian, nutritionist, behavioral specialist, because, you can lose the weight and gain it back, right? So it's really important that it's not like just like anything else. One, it's a surgery, but also it has to be in a way where this is sustainable. So comorbidities, I'm not going to go too far into it because I'm going to let Rose kind of continue on to the future research. But again, nephropathy, hypertension, dyslipidemia, retinopathy, neuropathy, obstructive sleep apnea, PCOS, metabolic dysfunction associated with liver disease, important psychosocial factors, and preconception counseling. And we talked about that with those rate of pregnancies and rate of complications. So I'm just going to end a little bit with a case because I feel like sometimes you read this stuff and it gets you a little down. But this is a 14-year-old type 2 diabetes. So I do want to give a little bit of a plug. We did start a type 2 clinic. It's the second Thursday at Landerbrook. Again, we see people on the west side and the east side. So obviously not everyone can come to Landerbrook. But I think what's nice about starting that multidisciplinary clinic, it's me, it's Marley, which is one of our nurses that will soon be taking on a role of a nurse practitioner, but it's also Jennifer Dorman, who's our nutritionist. It's Karen, who's one of our social workers, and Dr. Landis is also there for that mental health component. And she really kind of talks to families more in a health lifestyle coach. So she goes in there and really tries to see what can we help with, because a lot of times there's other factors, maybe underlying ADHD or underlying other things that aren't treated. And she can help with a lot of those different things as well. So this is a 14-year-old presented. It's the first time I saw this patient in type 2 clinic. A1C was 14%, but like long-standing history of elevated A1C. There were some social stressors. They were not checking sugars at home. So we did ketones. They were negative. Blood sugar on the meter was 230. He was feeling fine, elevated BMI, duration of about 3 years. He had tried the Libre, which is the sensor, but had liked it, but had trouble keeping it on. Current medications are metformin, Lantus, Victoza, short-acting insulin, but he's missing some of his meds, missing a lot of his short-acting. He does take his metformin, but some days he skips because of diarrhea, missing some days of his other medicines as well. So we really kind of went in, had a discussion about what can we do to help reduce your barriers? What can we do to your medication management as well? So we changed the metformin to extended release, and we changed to only 2 tabs a day. So those are the 750, so it's 1,500 a day. We switched from Lantus to Tresiba, it's a little longer acting. We increased the dose to 60 units. We switched from daily Victoza to weekly Trulicity. We stopped the short-acting insulin, and we started Jardiance, so another non-insulin agent at 10 milligrams. We actually started the Libre 3 sensor in clinic with the overlay patch, what helps keep it on, and also gave him skin tack, so kind of gave him some tools and tips for helping keeping the Libre on. We saw him back in follow-up, and remember his A1C was 14% and had a long-standing history of elevated poor glycemic control. And so we had an A1C at the next follow-up, and it was 7.6%. So again, not everyone, as we've said, lots of data of beta cell deterioration. So it's not everyone who we make changes, we see these dramatic improvements. And maybe it was just because he only had it for 3 years. But I guess what I want to say is, yes, the data shows that we need to be thinking about things early. We need to be intervening early. We probably need to be adding secondary agents earlier. But also that, like, you can't, sometimes when you make these changes, you really can see significant improvements. And so having those conversations and seeing what we can do to improve things is important. And it also is important because having that secondary support of having social work there, our social worker did follow up with the family, having that support of having CGMs in clinic directly, so we can start people on CGMs, we can give them skin tack, and give them overlay, because just telling someone that you sent a script to the pharmacy, if they've already had trouble putting it on and keeping it on, you just sending it to the pharmacy, probably you're going to see them back, they're still not going to be on the same CGM that they weren't on when you saw them originally. So making sure you not only have some samples, but also have those, because you do hear that a lot, where either you have some issues like skin irritation, or you have issues with keeping it on. And so it's really important that you have those tips and tricks available, so you can kind of see what is the barrier to keeping it on. And Libres are 14 days, Dexcoms are 10 days. We'll see a lot more Dexcoms because Dexcoms initially were the only ones that integrated with pumps. So now Libre will integrate with like iLid and some of the other ones. But in general, that's why you see it more. But, you know, Libre 3s are also very small, and they are 14 days. And so, you know, there are different CGMs available. And really the last thing I just want to say is just when we think about type 2 diabetes, you know, it's really important that we kind of, because a lot of times what happens is people feel okay with their A1Cs are high. I mean, some of them have this risk of decay and HHS, they might present in the hospital, but some people may ride a really high A1C for a long time, and they may have barriers to having clinic and kind of fall off for care. Versus type 1, you know, you stop your insulin, like you will present in DKA, right? Like we will see you. So just important to know in the general pediatric community, if you see someone and their A1C, you know, is above goal, but you're like, it's not so bad, you know, that it's really important that we know most likely they come back to you 6 months later, a year later, now their A1C is like 10, you know, so it's really important if they've fallen out of care, try to get them back in and see if maybe there's other things, because there's so much more available now than there was even, you know, a year or two ago, and really try to get them back into clinic to see what can we do to really help them and are there barriers. So that's where I'm going to end. I'm actually going to defer questions until Rose kind of talks about future directions, because it's always exciting to know what's going to happen next.
Thanks, Anna. That was incredible. It's been incredible to have Anna here and just sharing her passion. The Type 2 clinic is really up and running. I want to thank Anna for all her efforts in such a short time, and Jamie Wood, who I think is her real mentor and her real support in all of this. So it's been great. We have an incredible diabetes team. I know that many of you interact with us on a daily basis. But now I want to turn to discovery, because I think, Anna, the key thing that you said over and over was earlier, and what the hallmark of medicine is prevention. And we are not able to prevent type 2 diabetes in youth yet. And so that's what SEARCH and RISE and Today have led to a new study that NIH has, we just launched recruitment in October. So I want to tell you a little bit about discovery of risk factors for type 2 diabetes the data that we're going to collect, the gaps in knowledge that we hope to fill. And I think looking at all of you in the general pediatric world, this is for you. This is so that you can help us to identify these kids earlier, because when they present with type 2, we know it's too late. Their beta cell failure, as Anna has said, is really is really complete. So we need to catch these kids earlier and hopefully reverse the underlying pathophysiology. So anytime you start a new study, what are the gaps in the knowledge that you hope to fill? So we know, you see it in your clinics every day, that while childhood obesity is common, not all obese children will develop youth onset type 2 diabetes. So how do we really identify the children at risk for type 2 diabetes? And that's a real goal here for discovery. What are the early physiologic drivers that really push a kid across the spectrum from normal glucose tolerance to prediabetes to type 2 diabetes? What's the tempo? We really don't understand how long a child stays in prediabetes. There are some kids who develop prediabetes and are able to revert to normal glucose tolerance. But we need to understand more about this progression and what the drivers are, so that the hope is that we can do more targeted intervention in the future. What are the psychosocial risk factors for youth onset type 2 diabetes? The search study, more epidemiologic focus, certainly identified that there is an underlying racial and ethnic propensity to develop youth onset type 2 diabetes, but there are other social determinants of health, including the built environment that our families and children at risk live in, that also drive this. So it becomes, and what Discovery hopes to illuminate is not just the physiologic, but also the social drivers, and what are public health initiatives that might also help us to prevent youth onset type 2 diabetes. And during puberty, and I'll show you a few slides, we know that puberty, there's this physiologic insulin resistance that develops. But what we really don't know is what is the normal range of glucose in children as they progress through this puberty and this physiologic insulin resistance. Are the cutoffs that the ADA and that we use every day for diagnosing diabetes, diagnosing prediabetes, are they really applicable to children, and are they applicable during puberty? Because we know that most youth from Search and Today who present with type 2 diabetes in youth present by Tanner stage 4. And so we really need to be looking at early pubertal children, Tanner 2, Tanner 3, and identifying those, again, who are at risk, who are developing and not able to, their beta cells are compensating, but are starting to burn out, so that we can reverse type 2 diabetes. And so it's really kind of challenging dogma a little bit. These are the cutoffs we've used since I was a fellow here, started here 25 years ago. These are the cutoffs that we've used historically, but I think has been said in this auditorium multiple times, children are not small adults. And are these cutoffs really what we should be applying to? And there's a few studies that suggest that the glucoses do go up a little bit, but maybe we need to have different thresholds for really identifying those kids at risk. We know type 2 is more common in females. Why? We don't really know why. And why is Tanner 4 really that likely stage for type 2 presentation? So it comes, a lot of the planning and discovery really focused around puberty and this potential window of physiologic opportunity. There's been some small studies that have looked, why do we have this physiologic insulin resistance? It's all those hormones of puberty. It's the growth factors. And here is on the right, the open boxes or open dots are the IGF-1 peaks in girls and boys. And then the dark circles are the accompanying increase in insulin needed to maintain glucose homeostasis. But we know that there are differences among youth, non-Hispanic Black youth. There's less of a compensatory increase in insulin. And anytime your insulin can't compensate, you're going to have a higher risk of dysglycemia. We know that there is at baseline in children at risk some high baseline insulin secretion relative to their insulin sensitivity. And this is something that we call the disposition index. It's kind of the new metric that in a lot of diabetes studies we're using, because it combines not just insulin resistance, but this fact that the beta cell is not functioning. So how is secretion relative to your state of insulin resistance? So the disposition index. And so these can change and be different in different populations. And there can be in Hispanic populations some transient fall off. And so if you're not able to compensate, you're going to end up with dysglycemia and hyperglycemia, and then on your path to type 2 diabetes. But these are small studies. So if I have a schematic, and this helps me to think about really what Discovery is trying to do, is everyone in early, the x-axis kind of shifted there, but Tanner stages 1 through 5. And if we pick insulin resistance as a metric on the y-axis, everybody has an underlying predisposition, genetics. Puberty causes your insulin resistance to go up, as we talked about epigenetics for this physiologic rise. But then you add obesity and you add other risk factors. Maybe you have a family history. And so we know some of the risk factors. If you had in utero exposure to gestational diabetes, you're at higher risk of developing youth onset type 2. If you're born SGA, you have an increased risk. And then there's other environmental stress, so these social determinants that impact our youth. And, some kids are able to ride the wave of insulin resistance during puberty and come out in normal glucose tolerance. Others will develop prediabetes as youth and then go on in adulthood to potentially go on to diabetes. But some youth, and the ones that we're really worried about, are those that the insulin resistance, they aren't able to compensate. It continues to rise, their beta cells fail, and they present as children with youth onset type 2. And so in Discovery and in our analytical approach, we talk about looking at trajectories. And what if we could give you an insulin resistant growth chart that in clinic, you have a Tanner 2 kid and you have a metric that we've defined in a prediction model that says, this is the kid who's going to be on the red curve. And now I know, because of my physiology studies through Discovery, that giving a GLP-1 by Tanner 2, I can prevent this kid, because the one positive in a small group of participants in today were able to go into diabetes remission or durable control. Their thought was that they were able to be intensively managed during this critical time period of puberty, and they were able to ride the wave and go into normal glucose tolerance. So how do we get more kids into durable control? And we really, unfortunately, we know a lot, but we don't know enough. We need to understand these early years better, and that's what Discovery is about. So our goal is really to extensively phenotype a large cohort of youth at risk for type 2. So using the risk factors that we know right now, monitor them, characterize them through puberty, and look at both the epidemiology and the pathophysiology. And I'll show you our protocol in a couple of more slides. So we really want to come up with a prediction model that can be translated to primary care, that we're going to be able to identify these kids, as well as figure out what is the target for the next intervention trial, the next today's study, so that we can intervene and hopefully prevent youth onset type 2. And the second objective along the way is, we're seeing kids every 6 months. We're storing a lot. We know what we think might be the key physiology metrics that we should look at, but there will be other discoveries from other studies. And so we're biobanking a lot of these samples along the way so that we can go back and do further investigations. Actually, just giving the fiscal state of the NIH and everything, this study is really built in 2 phases. The first phase is recruiting and starting the study and collecting. And the second phase, because it's more cost effective, we will then be analyzing the biology. So we're not looking at blood samples along the way. We're going to use the biobank at the end to do what's a case cohort. So we'll know we're powered to have about 280 to 300 kids develop type 2 diabetes, and we'll match them with a couple controls. And so instead of analyzing samples on 3,600, we'll analyze samples on about 900 kids. So it's a challenging, because along the way we will have very few metrics, but we will put our investment of time in really trying to characterize these kids and store everything for future analyses. So these are the distribution of our sites across the United States. There's 15 clinical centers. We will have the geographic and race and ethnicity distribution that Search has told us that this is the face of youth onset type 2 diabetes in the United States. And we spent about a year, a little over, talking about the science. What do we need to include? And in any clinical research study, what's the participant burden? How much can we ask of these families? Because we're asking them to join us for 4 or 5 years and come every 6 months and do a lot of rigorous science, as well as a lot of sensitive questionnaires. What is the right amount of burden? But these are motivated families who have been I felt that the long-term complications of type 2 diabetes in adults and in their children. They're worried about their children. And so there's a lot of passion and motivation there. And then just what can we afford to do within the dollars that NIH has so graciously provided. But, you know, we dreamed big, and then we came down to what is going to impact, what's going to be translatable, and what's going to hopefully bring the answers that we need. So our primary endpoint, the only thing we're measuring the whole time is hemoglobin A1C. But as Anna shared, you know, from today, it really, you can track the A1C rising in a child, and you can track their progression through normal glucose tolerance, prediabetes to diabetes. And it's now the assay is standardized across the gold standard assay, the one that you send to the lab from venipuncture, across multiple platforms. So we have a great assay. It is one of the ADA criteria. And the reality is many of us are doing less and less glucose tolerance tests in clinical practice because they are quite burdensome. And so we will be having our endpoint determining our cases based on their A1C greater than 6.5% as our diagnostic criteria. And this is, again, thinking about what can we do in a primary care office? What are the metrics that you're going to be able to obtain? And, you know, a single non-fasting blood sample is very attractive. And then we have a lot of secondary endpoints that will correlate with these A1C trajectories over time. And these will come from the gold standard 3-hour frequently sampled oral glucose tolerance test that we'll use as kind of the background later. As I said, we'll analyze the samples, looking at glycemia, looking at beta cell function, looking at insulin sensitivity and clearance. You have to go 3 hours with the glucose tolerance test to really learn about free fatty acid and the flux through the body. And that, from other smaller studies, is thought to be where we can really learn more about the physiologic drivers in these children. And then GLP-1 receptor agonists, we've never measured incretins. It's actually tricky. It's a special tube. It requires immediate special processing. It's an expensive tube. But clearly, this is what we need to know about, is that is the in vogue drug. Is that the medication that's going to be able to prevent type 2 diabetes in youth as well? And so we'll be storing those samples as well. So this is our these are our inclusion criteria. 3,600 kids is what we're looking for based on power analyses. We're going to recruit 9 to 14-year-olds. You have to have all of category A. You have to be overweight or obese with a BMI greater than 85th percentile. We chose kind of a weaker BMI percentile because South Asians do present with type 2 diabetes in youth at lower BMI. So wanting to make sure that we're inclusive of all of our potential at-risk groups. We started with 9 to 13 for girls, and just acknowledging that puberty starts later in boys, 10 to 14. We want them to be Tanner 2 or 3, so they have to have entered into puberty, but we want to be able to follow them long enough. So you can also be up to Tanner stage 4, but if you've initiated menses, in your Tanner 4, you will not. But if you're Tanner 2 or 3 and you had early menstrual initiation, that's okay. Again, based on our knowledge that Tanner 4 is the most critical time. We want to be able to see these kids get a few samples, and then they present hopefully with type 2 diabetes. So we do have buckets. You know, we're hoping to have 80% Tanner 2, 3, 20% Tanner 4. And then, you know, we have 4 or 5 years to do this study. And so we have a distribution of our A1Cs. We have 75% that will be pre-diabetes coming into the study, and about 25% that will still be in the normal glucose tolerance range. And then you have to have one other risk factor from category B: a family history in a first or second degree relative, personal exposure to gestational diabetes, an A1C greater than 6. So you're really getting close to diagnosis, severe obesity, BMI greater than 99th percentile, and then any of the other risk factors I mentioned before, IUGR, SGA, low birth weight, also puts you at a higher risk. So that would be another tick that you would be eligible. Lots of exclusions. Anybody who, any known syndrome that predisposes you to diabetes, and in medications, if you're on inhaled steroids, prior treatment with insulin, a few things that we're starting this study as many of the GLP-1 receptor agonists are being approved for obesity. So there's definitely, we felt the time that we needed to get this study launched before a lot of kids are started on GLP-1 agonists, although we are not allowing them to enter the study if they're on, but if after they enter, the family decides they want to start one, we cannot tell a family that they can't, and actually it will be an interesting secondary analysis if enough of these kids actually go on GLP-1 receptor agonists, that we can look at their beta cell function and their over time after they start. So all of that will be tracked, but coming in, they need to be at least 6 weeks before, not have been on a GLP-1 receptor agonist for weight loss. They can be in a weight loss program, but not on medications. We are, A1, with regards to using the A1C metric, it does limit us a little bit, because if you have any underlying anemia or condition that predisposes to anemia, any hemoglobin variance, that your A1C can be inaccurate over time, and that's what we're following. The trajectories are, so we are going to need to restrict entry based on that. And then because puberty is such a large part of our hypothesis, any use of estrogen, testosterone, GnRH agonists that might alter the course of puberty is also an exclusion criteria. I want to leave time, so I'm going to go quickly through the last slides. This is our study design. There's a lot of pre-screening. EHR makes this easy to find the right age range, the right BMIs, bringing them for screening. They'll have that A1C for the inclusion criteria. They'll have a CBC to avoid anemia and hemoglobin variance. They'll come in for a baseline. These annual visits are long. They're about 5 hours. They get blood, they get urine. We'll do a stool sample for microbiome at baseline. They'll have a 3-hour OGTT. They'll have an A1C. And we're so fortunate to get a donation from Abbott to use the Libre sensors every 6 months on these kids. So as you know, we'll have that. Looking at just the A1C as a point in time, it's incredible, well standardized marker, but using continuous glucose monitoring, we'll see what these kids day and night at home eating their usual diet. What is the normal glucose excursion range for kids during puberty with these risk factors? And is there, we'll see, is CGM a part of screening for those at risk for type 2 diabetes in the future if they spend 20% of their time over 180 or something like that? We'll do an exam. It's denoted their kind of limited exam. Tanner staging, none of these studies have ever Tanner staged. Some people will do a survey where they circle, the child will circle, but this will be Tanner staging as we do in our clinics, because it's so critical to understand with regards to the pathophysiology. And grip strength in adults is a measure of your fitness. And so there's a fun device called a dynamometer that you can measure grip strength. And so as we were practicing, I think the kids, all the coordinators, I even had fun trying to see what your grip strength is. And so I think the kids will have fun, and that will be something, a new measure is grip strength and fitness related to your risk of youth onset type 2, and a bunch of questionnaires. At 6 months, it's a much shorter visit, about an hour. They have the CGM placed again. They give some fasting blood and a urine sample, their A1C, and then we do these little quarterly check-ins, which is just a phone call or an email, etc. These are the child questionnaires, which are really diverse. We are looking at anxiety, depression, eating disorders, and other risk behaviors in adults, and we give times, because when you're talking about burden, how many questionnaires, how much time does it take? For the adult, we're really interested in understanding what is their discrimination in medical settings, what is their social support, what is their spiritual support, what is their family cohesion, what is their neighborhood like. We tried to construct a series of questionnaires that will really give us a picture of the social determinants of health, as well as psychosocial lifestyle and behavior of the children in our study. Notably, too, part of it is we're going to be getting residential history all the way back, hopefully, to where they were born, so we can really understand and link this to, these are geocoding, link this to databases on area deprivation, what's their social vulnerability of the area that they grew up in, what was the childhood opportunity index, a lot of measures that we'll be able to hopefully correlate and their impact for youth onset type 2. These are all the specimen. We have a lot of ideas of what we want to do. Of course, genetics and microbiome, metabolomics. I mean, a lot of ideas. And we're just now, even in phase 1, starting recruitment, planning for phase 2, what we want to specifically measure. But we have been diligent making sure we're saving enough samples over time. Long timeline goes out to January 2029. So we did all our planning. We're starting recruitment. These targets are really high. We're still ramping up. We have, as of yesterday, about 9 sites enrolled. But hopefully, I really hope in 4 or 5 years, I'll come back and give you an update on what discovery tells us and how we can hopefully prevent youth onset type 2. So quick summary, Anna showed us that The number with type 2 is rising. This is different pathophysiology than adults. It's much more rapid beta cell failure. It's tough to treat. We have new agents available, but it does take a dose escalation. The course is aggressive. Kids will develop complications in their early 20s when they should be in the prime of their lives and starting their working lives. We need to prevent. We need to understand more what will be the clinical, what will be the public health efforts needed. We need a diverse perspectives, and that's what this investigative team that has come together. And we need, the pipeline. We need parallel approaches. There are kids now in Anna's clinic that need to be treated, so we need to keep approving drugs for use in children, but then we need these hardcore epidemiology, physiology studies to really guide us in the future and personalize the approach. What is the time period? What is the target? What is the intervention that will reverse this course? So a lot of fun. Thanks. This is all study group. It's fun to be in these multi-center studies. I want to thank all of the participants in the studies and in this consortium, the investigators. It's come talk to me if you're interested in doing this type of work. And this is my favorite picture of rainbow babies. This is from the end of my fellowship. These are all Peds Endo fellow babies. This is my tough guy on the end, who was the youngest of all five. And he's now 19 and off at college and sending him back again tomorrow. Anyway, so it's been a fun time. Thank you, all my collaborators here at Rainbow and Case. You want me to go back? You need that CMA sign? Okay.
Yeah.
There you go.
That was fabulous. Thank you both. I'm looking around the audience for.
This is next day hour for Dr. Nyman. What I'm curious, what you've been seeing with the GLP-1s at the doses you're using for diabetes rather than weight loss. What have you been seeing in kids in terms of any effects on depression or suicidality? Is that something that's shown up for you at all, or not really been an issue?
So it's a good question because we always counsel, right? Is any GLP-1, there's been, although the data like initially came out and then the most recent data show that maybe it doesn't increase the risk. But I think that in clinic, we don't see it so much. I do want to say that especially those who have an underlying history of depression, like those that are already treated on medication for depression and anxiety, or have had a history of suicidal ideation, those are the ones that I'm most concerned about. And so those are the ones that I really kind of counsel more. But in clinic, I have not stopped anyone in those with type 2 diabetes. I have not stopped anyone for that indication. Although I know that there has been some cases in weight management.
It's always been my observation that when we have a big problems complex, we look at the consequences and start measuring everything. But when in fact, we're not looking at why this is really happening in terms of measuring that. So you mentioned exercise, diet is important. But in these studies, there's no clear sense of how diet is being measured and is it changing? And does that correlate with the change in their the measurements you're making, and same with exercise, and whether or not you've looked at athletes and their BMI, not their BMI, but their glucose monitoring, how they tolerate glucose or not, whether exercise is actually making a difference in terms of when they hit stage 4 of puberty. Is it different? And so at least you can get a handle on that. So one is, I think we can measure whether people are exercising. You have a room with either a stationary bicycle or the track where you walk on it. Treadmill. Yeah. The word age has a factor too. So the treadmill, you put them on that for 10 minutes and measure their vital signs and see how they respond to it, and say, I want you to do this. I want you to walk a mile 3 times a week or whatever. When they come back, measure the same. And I guarantee in a month, you will see a difference in their heart rate. I guarantee it. So it seems to me you can't be monitoring whether or not they're complying with exercise guidelines. And diet, to me, is also such a problem in terms of influence, because what you can buy at the store. And so few days this past month, I've been looking at it. Anytime I eat something that comes from the store, besides fresh vegetables, so anything in a bottle container, you look at it, added sugar, 20 grams, 20%. I can't believe it. I had a salad, I put vinegar on it, and it tastes so sweet. I looked at it, 20 grams of sugar added to a bottle of vinegar. Well, you're eating vinegar because it has a different flavor to it. It doesn't want, I don't want it to taste sweet. So it's, I don't know whether you looked at the correlation with the increase of diabetes and the quantity of sugar added to products. I'm willing to bet there's a correlation.
So they have done, that was actually in the original today, so maybe Rose can even mention it more, but they really did look at lifestyle intervention. And they found that by itself, it was not enough. However, there have been a lot of studies really looking, I mean, there was a huge study here at Case. Again, Rose can talk about this more. I think that there has been studies that have shown improvement with lifestyle. I think what they've also shown is that it's very hard to maintain because of a lot of the things that you're talking about. So many things have added sugar in them, and so there has been a lot of data, but then the data is showing that we need other things as well. But I'm also going to let Rose speak because that was actually one of the original things with the Today study.
Yeah. I think so in the Today study, they had PALs, personal lifestyle advocates, that worked with all the families that worked on their activity. But it is moments in time when you're interacting with that individual, and did they continue? But they actually did do treadmill testing in Today. They also did it, so you can use a treadmill or a bike, a stationary bike, to do these exercise tests. They did that in Today, and what came out of it is that it's just in some kids it's enough, in other kids it's not. There's just and the feeling going into Discovery, as NIH planned this and brought investigators together to help to advise on this, is that unfortunately, just as we said, not every obese kid will develop type 2 diabetes. There are graphs, I've seen them, where, the rise in added sugars and the rise in obesity, and here we go with youth onset type 2 diabetes, definitely links, but not every kid. So the idea and the thoughts are that it's just more complex, that lifestyle is the foundation, as Anna said, but it's not going to work for everybody. We actually you can't fit everything into one study, but we have an ancillary study for activity and looking at dietary. We're doing some questionnaires, but not doing detailed dietary surveys. But we are seeking additional funding to add those to Discovery. The cardiopulmonary, the exercise tests were brought up as well as being a real measure. How fit are these kids? Is it the, again, metabolic and healthy, fit, obese kids that are not, and how not developing type 2 diabetes, and trying to characterize that more. But we do the thing, as you said, we're going to have CGMs, continuous glucose monitoring. What are the glucose excursions on the kids? And we do have an activity ancillary that we're looking at, that we're the world actigraphy, looking at their sleep patterns. Are kids not sleeping overnight, and that's why they're not active during the day? Is it because in their area where they live, there's sirens overnight and they wake up and their sleep is disturbed, and then that leads them the next day to have less activity, more food consumption? So these patterns, and they're definitely interventions that can be focused around these patterns. So, well, we have a lot to learn. Good question.
Thank you guys so much. I'm quite sure that we could continue
Yeah.
questions throughout the morning, if not through the day. And I'm really looking forward to that follow-up grand round. But I also see that we're past the hour, and I know how very busy things are upstairs. So one last round of applause and we'll all get to work.
Great job.